Hello, I'm Bob Chaloner, the Chief Administrative Officer at Stony Brook Southampton Hospital, and I'd like to welcome you to another edition of Focus on Stony Brook Southampton Hospital, your monthly program about the people, the events, and the services at your community hospital. We always have special programs. Today we have one that I'm particularly excited to kick off. It's one of our very dedicated and wonderful doctors will be a urologist, and we'll talk a little bit about what a urologist is. Dr. Robert Munkelwitz, who's been with this hospital for a number of years, and for many years almost single-handedly ran our urology department, and he's here today to talk about prostate cancer, something that at least 50% of the population needs to think about. We're going to talk about how it may be prevented, how it's treated, and what to do to find out if you do have prostate cancer. So Dr. Munkelwitz, thank you very, very much for joining with me, and thank you for your years of service at the hospital also. I'd like to just ask you, tell us a little bit about yourself, how you ended up becoming a doctor and a urologist, and what brought you out here to the East End.
Well, thank you again for inviting me here to speak on this very important topic. I came here to Southampton in 1991, shortly after finishing my residency at Stony Brook. I'm a local Long Island boy, grew up in Sayville, about the mid portion of the south shore of Long Island. Had family here on Long Island and wanted to stay in the general area. This was an area that was identified as being somewhat underserved in the specialty of urology, and we came out in 1991, my wife and I, and started the practice, which has grown over the last 21 years into now a two-man practice, myself and my partner, Dr. Sobey. I got interested in urology during my medical school training. It was an area that was very appealing to me. It had a little bit of everything, it seemed. It had a little bit of surgery. It had medical aspects. It had both men and women, had both young and old, and had aspects to it that were part primary care. Some of them were very episodic treatment like you would have in a very strictly surgical practice. So it was something that appealed to me from an early time in my training in general medicine, and that prompted me to go and become a urologist. In terms of my areas of interest in urology, I'm a general urologist. Okay. We basically see different types of diseases. Urologists in general will treat diseases of the genitourinary system in men and urinary system in women. Right. As I said, we see both young and old. A lot of the diseases that we see are prostate cancer, as we're talking about today, is a disease that tends to be of older men. But many diseases that we see, stone disease can be in people in their 40s. Different things like infections may be seen in younger people. Stone disease sometimes seen in younger people as well. So we do have this area of general commonality with a lot of our primary care colleagues. And it is a nice aspect to the practice. Yeah,
and I've heard that said about urology, that it does kind of span everything from primary care to medicine to surgery. And I know that it's urologists definitely are very skilled surgeons, and also definitely treating people from a medical perspective. I think that's fascinating, where we tend to see doctors divide either surgeons or medicine in other specialties.
It was a very appealing aspect to it from the standpoint that you do get to be the primary care person. For instance, for someone with prostate cancer, a lot of time the urologist will be their primary care. You'll work as the intermediary between their medical oncologist, their radiation oncologist. Sometimes we have people that are strictly urologic surgical oncologists that work with patients, but will still be sort of their intermediary, their quarterback, if you will. So that's a very appealing aspect to what we do here, particularly in our community.
And you mentioned you're a general urologist. Is it true that there are subspecialists within urology as well?
There are a number of recognized subspecialties, and this has been the trend in medicine in general, this so-called super specialization, where people are just strictly urologic oncologists, that all they'll deal with are cancers of prostate, bladder, and so on. There are people who are strictly pediatric urologists, and all they'll deal with is the pediatric aspects of our specialty.
Okay.
These are, the trend in medicine is towards that, but we here mainly do general urology. Most people that need a urologist, probably 90% of them need just a general urologist, maybe only a 10% or so that have something that's unusual or considered an area where a subspecialist may provide some benefit.
Right. And I think it is worth noting again that you, for quite a while, you were our solo urologist in this community, and I'm glad we didn't work you out. The community owes a great deal of gratitude to you for all the coverage you've provided day after day for many years here. So thank you for that.
We're fortunate living where we live,
Yeah.
and we do have a really wonderful community, and it's been my privilege to serve the people that I take care of.
Thank you for that. So today we're going to talk about prostate cancer, and I don't want to assume that our viewers know anything about anatomy. Let's talk a little bit about the prostate. What is the prostate and what does it do?
The prostate is a gland that sits at the base of the bladder.
Right.
It's about the size of a walnut. It's adjacent to the rectum. It lays, as I said, at the base of the bladder, and the urethra, the tube through which we urinate, passes through the center of it. It is the main purpose of the prostate is its function in the reproductive tract of men. It basically serves to produce fluid for semen in the ejaculate. So in that aspect, it does hold a fertility function, but it is thought maybe that it does have some aspect in terms of prevention of infection in men as well.
Okay.
But the actual purpose of it, people ask sometimes, can I live without my prostate? The answer is yes.
Okay.
It's not an essential organ. It's sort of like your appendix. It does something, but it's not something that you cannot live without, unlike
Right.
your kidney or your heart or your liver or something like this. It is an organ that certainly serves a purpose, but its definition and its exact function is understood to some degree, but there are maybe aspects to it that we don't, immunologic function and so on.
So not like a gland that's producing a hormone or anything?
Correct.
Okay.
Unlike your thyroid gland
Right.
or your pituitary gland or your adrenal gland, this is an organ that, again, may have functions beyond what we understand in terms of its fertility function, but it may have, as I said, some people think about immunologic function of it and so on, but it's really a gland that is not life essential.
Okay. And as we age, men we start to hear about prostate cancer and getting screened for it. Can you tell me a little bit, what is prostate cancer?
Prostate cancer is, as all cancers are, an abnormal growth of the cells within the prostate, and how it develops and how it occurs. There are a number of theories on what's called carcinogenesis in general, but it's thought that over time abnormalities within the DNA of the cells accumulates, and those abnormalities as we age become amplified and more prominent in the cellular material, and they can lead to these abnormal growths of tumors, which then have the properties of cancer. And one of the properties of cancer is that it can invade into local structures. It doesn't stay confined to the organ. In this instance, prostate cancer can invade into the seminal vesicles, which are adjacent structures to the prostate, can invade into the bladder, can invade into the rectum locally. Or it can spread, or what we call metastasize, where it can travel through the bloodstream, through the lymph nodes, to the bones, to other organs, the liver, the lungs, and so on. So these are some of the characteristics of what makes cells cancerous. In particular with prostate cancer, we don't know exactly what causes prostate cancer. We are aware of some of the things that are risk factors for prostate cancer, and some of these things I alluded to with regard to age. We know that prostate cancer tends to be more common in men as we get older. It's rarely seen in men that are less than 40 and becomes very common. In fact, I often tell men in their 80s that if we looked hard enough at most of them, they would have some form of prostate cancer.
I've heard that said that if you live long enough and you're a man, your chances are you are going to get prostate cancer. Is that true?
This is to some degree true, but again, the There's a difference between what is considered clinically significant prostate cancer, that is, say, a cancer that could cause you harm or be fatal, versus a cancer that may be just incidental and just be living within the prostate.
Right.
There are other things that we think are risk factors for prostate cancer. One of them is ethnicity.
Okay.
We know that different genetic groups appear to be at higher risk for prostate cancer. In the United States, African American men are known to have a higher rate of prostate cancer, and indeed maybe a higher rate of more aggressive forms of prostate cancer. They tend to be diagnosed at an earlier age. These cancers can develop at an earlier age and can move more aggressively. That basically is something that you see throughout different geographic regions. There may be higher incidence in North America and other areas, for instance, in Asia and Hispanic people have a little lower risk of prostate cancer.
Okay.
So this is something that we see. One of the other factors that we see with regard to development of prostate cancer is family history. That if you have a first-degree relative, that is to say a father or a brother or a sibling
Right.
or a child with prostate cancer, your risk of developing prostate cancer may be 2- or 3-fold over that of the normal individual. And
Is it because there's a genetic component, they think, or is it
there are
something-
certain genetic
Yeah.
components that have been
Okay.
identified that have been linked with prostate cancer,
Right.
and that's probably where that comes from. That may be part of the ethnicity component, but the other part of the ethnicity component may be environmental factors, lifestyle factors, factors related to your diet, things like smoking, things like obesity and weight. We know that. For instance, I brought up the fact that African American men have a higher incidence of prostate cancer, but Africans that live in Africa actually have a fairly low incidence of prostate cancer. Now, there are different genetic groups for sure, but there may be similarities there enough that you'd say, well, how can that be so different?
Right.
And it may be these environmental factors that are part of this. We know that diets that are high in fat, high caloric diets, maybe diets that are higher in refined sugars, low in fruits and vegetables and things like this may pose some risk to people with prostate cancer.
You mentioned tobacco. Is that an issue too? It seems like tobacco is implicated with virtually everything.
Certainly not good. It certainly is something that does increase one's risk for dying from prostate cancer.
Right.
Whether it is an actual carcinogen that leads to development of prostate cancer is less well established. Certainly know very well with lung cancer. We know very well with bladder cancer, but prostate cancer less so.
Okay.
But it wouldn't be something that we one of the lifestyle modifications that we would ask someone to make if they were diagnosed with something like prostate cancer.
Are there different forms of the cancer? Like when we talk about breast cancer, for example, there are various types of breast cancer. Is that true with prostate cancer
There
also?
are different types of prostate. There are different types of cancer that can develop within the prostate or that are
Okay.
considered prostate primary tumors. But the most common type is what we call an adenocarcinoma. Adeno refers to gland, the prostate being a gland. This is the
Right.
type of cancer that it gets, and this is the most common type that we see. And that would be probably more than 95% of the type. We occasionally see unusual things, small cell carcinomas, neuroendocrine tumors, things like this, sarcomas, but they're fairly rare. The prostate cancer that we see, this adenocarcinoma, is one that is very common.
Because it's in the reproductive system, are there risk factors associated with sexual activity or venereal diseases, or is there any link that's been found with any
Very
of that?
good question. That has been looked at. People have looked at different, whether different viral things could be a risk for prostate cancer, and none has been really well established to my knowledge.
Okay. Symptoms. How might we know we're starting to have prostate cancer, and are there any symptoms from prostate cancer?
I'm very glad that you asked that question because the truth is that oftentimes in the early stages of prostate cancer, there may be no symptoms.
No pain or
discomfort.
Okay.
When there are symptoms present, they can often mimic the conditions that we see in men of benign prostatic hyperplasia, which is a much more common condition, this benign growth of the prostate that occurs very commonly also in the same demographic of age, the men over age of 50, which can lead to slow stream of urination, frequency, urgency, getting up at night. Those sorts of symptoms much more likely to be related to a benign condition of the prostate, but certainly can be seen with more advanced stages of prostate cancer. As such, it's often, my recommendation is to most people that if they are having symptoms like that, they should speak with their healthcare provider about those symptoms. Again, most individuals, it's going to be a benign condition. It's not going to be cancer, but these can be early warning signs sometimes of a disease process that is in its early development. There are more specific symptoms of, not more specific symptoms, but other symptoms of prostate cancer that you can see as one gets to later stages of the disease, things like weight loss, localized pain, blood in the urine, blood in the semen or the ejaculate, bone pains, things like this. But these tend to be less common. Most of the people that we diagnose with prostate cancer do not have these symptoms. They're found for some other reason.
So that I'm suddenly having to urinate more often at night or just having trouble urinating, that to you would be a red flag to at least come in and get checked.
I think it's something to have a conversation with your healthcare provider about. Again, these may be normal symptoms of aging, but if taken in the context, if they're new, if they've developed over a short period of time, there may be some reason to look a little bit deeper and closer at them to make sure there's not an underlying problem.
Right. Is that something most men experience as they get older too, some of these symptoms? Or?
The symptoms of benign enlargement of the prostate are very common. As I said, men over the age of really 40 will start to experience some change in their urinary symptoms, which is normal, it's age-related, and can be explained by these benign processes. But as we alluded to earlier, there can be some overlap with those types of symptoms and with conditions such as prostate cancer or even bladder cancer for that matter. So if they are new symptoms, it's worth just having that conversation with your doctor, and oftentimes simple tests, urine tests, blood tests, things like this will help give guidance to whether further intervention or further evaluation is needed.
Okay, and can it be prevented? Is there anything you can do to, like some things like heart disease, they say run and don't smoke and eat well. I mean, what about the prostate?
Well, I think that you hit the nail right on the head. In terms of prevention, we know less about the prevention of different types of cancer in prostate. Here we're discussing, but even things like colorectal cancer and so on. What can we do to prevent those? We know from our colleagues in cardiology there's a very good body of literature that describes lifestyle risks that increase one's risk for cardiovascular disease: smoking, obesity, high cholesterol, diets that are high in animal fat. Oftentimes I'm asked by patients, what can I do to reduce my risk for prostate cancer? And I'll say, listen, why don't you follow the American Heart Association's recommendations regarding diet and exercise, because I would believe anything that is good for your heart is not going to be bad for your prostate. So that would be the prevention. I think cessation of smoking, extremely important. It is certainly one of the factors that is under-recognized and underappreciated in cancer development, I think.
It seems like the more research they do in smoking, the more they find that it's linked to so much damage in the body. So let's talk a little bit about that screening process. So you think you're concerned and you want to be screened. Can you just talk through what happens if some things people are afraid to come and be screened because they're afraid of a big needle or X-rays or something? What happens with a screening for the prostate?
Screening for prostate cancer is something that is an area that is controversial. Screening basically implies looking for a disease that may or may not be present in the absence of any signs or symptoms. So you're taking an otherwise healthy individual and subjecting them to some test to look for a problem that they may or may not have. When you do that, you want to show clear benefit of that process. You want to show that if you do detect this disease in this patient, and also that you are able to detect that disease in that patient by whatever test you're giving them, that you're going to provide them with some benefit, either in terms of longevity or prevention of complications.
Right.
Those factors with prostate cancer screening have not been satisfied to a very high degree, to the degree that most of us would like. And although many of us that take care of patients with prostate cancer believe that there's a benefit to screening, and there is some data suggests there's a benefit to screening, it's a complicated decision. Right. The American Urologic Association, of which I'm a member, recommends what's called a shared decision-making model, where you discuss with your healthcare provider the benefits and risks of being screened for prostate cancer. Things that you would give you maybe increased reason to screen, as we talked about. Older men, right. If they have symptoms of urinary symptoms, it may be reasonable to say, hey, could this be prostate cancer? Should we rule this out, or should we check to see if it could be this? People who have a family history, different ethnic groups that may be at higher risk for prostate cancer. Those may be populations that should be screened, but there is no clear answer in terms of should everyone get screened by prostate cancer. I'm often asked that question, and I'm glad I'm not in primary care, because right. The answer is I don't really screen for prostate cancer. Most of the men I'm seeing have already been referred or diagnosed. I will say, though, I am an advocate of checking PSA right. in most individuals. The American Urologic Association suggests that it should be done in individuals between the age of 55 and 69.
I was going to ask you, when do you start the screening?
Yeah, but there's some data that would suggest that maybe we should be starting the screening process younger, and maybe abandoning it at a younger age, even maybe in men in their late 60s, we don't need to screen anymore. And with people living longer, you can make an argument, well, maybe 69 is too young to stop the screening process. Maybe there is some benefit to screening individuals into their 70s or 80s. It's rare that you would need a screening PSA for a man, say, over the age of 75, and that's, again, a screening PSA. That's different than most of the individuals that I'm seeing in my practice that have either some disease state that they're being treated for, or have history of some prostate abnormality that we're monitoring. There's a difference. But it is a complicated question. It's one that's not easily answered. The U.S. Task Force on Preventive Health about 5 or 6 years ago came out with a statement condemning screening for prostate cancer, and this led to reduction in the number of screenings that were done by primary care physicians, and I think at the detriment to the population. Right. Recently, they've come back and they've repositioned that they say, well, there may be some benefit, and it is something that you should discuss with your physician, that there may be benefits to do it. I would argue that it's helpful information to know in the appropriate population.
Right.
I don't think you need to be screened if you're 40 years of age and you have no family history of prostate cancer, not in a risk group, and you probably don't need to be screened if you're a healthy man with no symptoms and have never had any prostate issues over the age of 75. But if you find yourself in that middle range, there may be a reason that screening might be beneficial to you, and it's something you need to discuss.
What's the downside to screening? Because it's
that's the part that people don't understand. Right. You know, there's consequences of all our actions in medicine, and right. whether we look or don't look, there's going to be consequences. If we don't look, you may have something and we miss the diagnosis, or arrive at the diagnosis too late. Right. If we do look, we may subject you to unnecessary tests. And in the case of elevated PSA and screening for prostate cancer, it may be a biopsy. Okay. You can have elevated PSAs that are false positives. They're high, they're elevated, they're suspicious, right. but they're due to a benign cause, such as enlargement of the prostate or inflammation of the prostate, and that can subject you to other tests. Those other tests can have their consequences, things okay. like bleeding, infection. More importantly, with prostate cancer, though, we may run the risk of detecting clinically insignificant disease. Right. There is a current thinking that a lot of the prostate cancers that we see may be indolent, meaning that they don't grow or won't risk spreading, and they may be able to be managed conservatively and without treatment, and won't harm the patient in any way. And the risk is maybe detecting something like that and then undergoing some more invasive treatment that can lead to longer-term side effects. So it is a difficult question. It's one that I, as someone who treats men with prostate cancer, wrestle with all the time. It's am I doing benefit, or am I potentially doing harm to this individual by checking this or doing this? And it's one that there's no one size fits all. It really is something that there has to be some thought about in the context of the patient, in the context of their age, in the context of their health, and in the context of their goals for therapy going forward, and what they see themselves doing in the years ahead.
And just for anyone who's not really sure, the PSA test, can you just describe that, what that
There's
is?
basically two things that we do for screening.
Right.
The main is the PSA test, which stands for prostate-specific antigen. It's a blood protein that's produced in the prostate. It's produced by normal prostate tissue, but it's produced to a greater extent in diseases of the prostate, in particular prostate cancer, so that when we see this value elevated above a certain threshold, that can be an indication of conditions such as prostate cancer that leads to to additional investigation. The other part of the screening process is the digital rectal examination, which is something that men often are very hesitant to have done for obvious reasons, but it is an important adjunct, even though it's not considered part of the screening guidelines, even by the American Urologic Association. I think it's an important part of there are two parts of the puzzle. You get the PSA information, and you get some physical exam information. The physical exam information may be important. If you feel an abnormality within the prostate, that may raise your index of suspicion for there being something going on in the setting of an elevated PSA. If you have a very enlarged prostate, that may be indication that the elevation of the PSA could be more due to an underlying benign condition such as BPH.
Okay. Could you just talk a little bit about treatment? What happens when you're diagnosed with prostate cancer then?
The diagnosis of prostate cancer is made usually by prostate biopsy, which is something that is done usually in an office setting, usually under local or just a local and sedative type of anesthetic. After that process is made, there's a number of things we need to know before we can reach treatment. We need to know about the stage of the cancer, we need to know about the grade of the cancer, and we also need to take into account the patient's underlying health, their age, their comorbidities, their health status that may affect their longevity. It's important to know that prostate cancer is a type of cancer that is highly treatable. It is a cancer that is, most men that are diagnosed with it are going to live more than 5 years, and with treatment, a fair number of those men are going to be cured. The type of treatment is really going to be very individualized, and again, that's one of the art of medicine type of situations where there's no one size fits all. It has to be individualized.
And what I'd love to do, Dr. Munkelwitz, because there's so many people concerned that affect so many people, it would be great to have you come back and talk more specifically in more detail about some of those treatments. I think would be wonderful, and living with prostate cancer would be a nice follow-up. But before we end today, can you just talk a little bit about some of the research that's going on, and are there any advances that you're particularly optimistic about? Seems like we need better tests. I'm sure the urological...
There's no doubt there's need for maybe better screening tests. There's need to answer these questions on who benefits from screening, to define our screening populations better. But there is ongoing research in many of these areas, both clinically with regard to treatment of localized prostate cancer, with regard to men that have advanced prostate cancer that's spread, that has failed traditional types of treatment. There's a number of areas that are under active research, looking at those, who benefits and who might benefit from which different treatments. This is a very optimistic time in oncology in general. We're really starting to really understand the cellular mechanics of cancer. We're able to target more specifically different mechanisms within the process of development of cancer, and the hope is it's going to lead to real great breakthroughs in treatment of not only prostate cancer but all cancers.
Wonderful. And one very last question for you. I often hear the term watchful waiting or active surveillance when it comes to prostate cancer. What is that exactly?
This is one of the things that's important, and this got to something we touched on earlier, that a lot of the prostate cancers that we find in men are going to be indolent or slow-growing types of cancers. And we're understanding now that a lot of these cancers may behave themselves and not need any sort of active treatment other than just close surveillance. And this idea of active surveillance is one that we're seeing now in prostate cancer. Different areas of oncology, some types of lymphomas are being managed the same way, where the individual is kept under very close supervision by a physician, monitored with different blood tests, maybe different imaging tests. In the case of prostate cancer, sometimes doing serial biopsies over time to see if there's any change in the grade or the amount of cancer. And this will lead us to whether the patient moves into a treatment group or remains in that surveillance group.
Okay, wonderful. Well, thank you so much. And there's so many more questions I'd like to ask you, and unfortunately we're out of time today, but we will get you back, I hope. And I would like to thank Dr. Munkelwitz for being part of our medical staff and serving this community for so long and so well. If any of you would like follow-up questions or would like to schedule an appointment with Dr. Munkelwitz or his partner, please call Eastern Suffolk Urology at 631-287-8600. And as always, if you have any questions or concerns or just need help navigating our healthcare system out here on the East End, you're welcome to call my office at 631-726-8555. As always, I'd like to thank our friends at CTV for producing this show and airing it in our Southampton communities, and I'd like to thank our friends at LTV for airing it in our East Hampton communities. Thank you for tuning in today. If you have any questions, please give us a call, and good health, everyone.